All right, so part 2, our upper respiratory alterations. Again, this is off of the review slides, so don't completely panic. But it's the same information, just in this kind of condensed form. These are the different alterations that we'll need to go through, and I'm going to kind of go through them quick so I can get enough of it in. All right, but first, we've got rhinitis. This is inflammation of the nasal mucosa. This is a patient just kind of has a runny nose. Okay, they have just irritation of the nasal mucosa, and it's causing the drainage, basically. So our manifestations are going to include headache, nasal irritation, sneezing, nasal congestion, and rhinorrhea. This could be bacterial, it could be viral. Different organisms. Oh, rhinorrhea. Well, does anybody know what rhinorrhea is? Runny nose. Yeah, that's just our runny nose. Treatments are going to depend on what the nature of origin is. What's causing the rhinitis? Antibiotics if it's bacteria. And then if it's not, if it is or if it's not, it's going to be management of symptoms. Okay? Antihistamines, kind of dry everything up. If it's it could be an allergy. You know, maybe just an allergy, a trigger that causes that irritation of the nasal mucosa. Antihistamines are going to help with that as well. Decongestants. Got to add an A in there, but decongestants. Singular is a big one. Antipyretics, and then relief of symptoms. Okay? And relief of symptoms is kind of using all of these. All right, sinusitis. And these are all very, very similar. The treatments are going to be almost identical. It's just inflammation or problems in different areas of the upper respiratory system. All right, sinusitis is going to be inflammation of the sinus mucosa. Manifestations include nasal swelling and congestion, headache, facial pain or pressure, facial pressure, and also pain. The pain gets worse as we tilt the head forward. Okay, so if you've got a patient with sinusitis, sinus infection, and they move their head forward, what happens? Those pressure changes cause, well, it hurts. Okay, it's because all that stuff is moving around in the sinuses. A sinus should be clear. It shouldn't have a lot of drainage in it. It shouldn't have any drainage in it for that matter. The inflammation, the inflammatory process causes the drainage, causes that fluid to build up in the sinuses. And those fluid shifts, that's what causes the pain. Same thing on treatments. Depends on what the type is. What's causing the sinusitis? Antibiotics if it's bacterial, analgesics if we've got the pain and fever, decongestants, steam humidification. A lot of times that helps. Okay, hot and wet packs over the sinuses, nasal saline irrigants or irrigations, increased fluids, and then FES procedure. FES procedure is basically when they take a big long needle to the sinus and they try to draw out or drain all the fluid. Okay, it's a trying to think of the abbreviation. It's a functional endoscopic sinus surgery. There you go. That's it. Go in with a needle and try to drain it off. All right. Pharyngitis, sore throat. Okay. It's inflammation of the pharyngeal mucosa, often occurring with sinusitis. Sinusitis and rhinitis. That's what that's supposed to be instead of pharyngitis. But it's sore throat. Okay. It could come from a number of different things. Probably the most common is going to be your strep. Okay. All right. Bacterial strep is the most common. Viral could be viral infection, or it could be irritants. Okay, it could be inhalation of something for anything from smoke, cigarettes, or maybe you had a bonfire. Maybe you were around a campfire. You're breathing in some smoke. It causes that irritation of the mucosa. The manifestations, well, obviously throat soreness, also dryness and pain of the throat, difficulty swallowing. Now that's a big one. Okay, difficulty swallowing. What could also result if if you've got a patient with difficulty swallowing, or what's commonly resulting the cause of difficulty swallowing. Yeah, the cause is usually swelling. You got a patient that has trouble swallowing, it could easily turn into, man, I can't breathe. So you really have to monitor. If you ever have a patient with any condition and they're having trouble swallowing, you really need to monitor that patient, because it could quickly turn to, I can't breathe. All right, fever commonly occurs as well, and then tonsil enlargement, redness, and this may result in a peritonsillar abscess, and then also tonsillitis. Just depends on the issue, but that's very, very common. Treatments, if it's bacterial, again, it's antibiotics, antipyretics for fever, analgesics for pain, and then from there, symptom management. All right, next, we've got influenza, okay, the flu. This is a highly contagious acute viral respiratory infection, okay? So when a patient says, I got stomach flu, are they talking about this? No. Is influenza going to cause stomach upset? It's not going to cause nausea, vomiting, diarrhea, anything like that. That's something else. That's probably just another viral infection, a GI viral infection. It's not going to be influenza. The influenza is only going to cause the respiratory issues. Yeah, exactly. Flu shot's not going to work for your stomach bug. Okay. Vaccination is going to be advisable. That's what we want to encourage as much as we can, especially to what populations? Very young, very old, and anybody that's what? Immunocompromised. Okay. Absolutely. Absolutely. Manifestations, general body aches, muscle aches, fever, and then the chills. Those are kind of the big three there. But the fever and the muscle aches, and then the fatigue and weakness, that kind of goes along with the body aches. Anorexia, and this is not like a patient with anorexia nervosa or anything like that. This is just they don't feel like eating. Okay, they're not eating. Sometimes days, caught a few days. Sore throat, cough, and watery nasal discharge. This can go on for several weeks, even after the influenza bug has been treated or not treated. Symptoms have gone away. The treatments, if the patient fits in the description of 24 to 48 hours after symptom onset, we can give Tamiflu and Relenza, antivirals. If they're outside of 24 to 48 hours, they're probably not going to give them anything. They're going to give them the antipyretics, analgesics, and antihistamines. These things don't cure the influenza. They just help with the symptoms. Even the Tamiflu and Relenza, it's not given to completely wipe things out. All it does is shorten the time that the patient has the influenza bug. All right. The next is laryngitis. This is inflammation of the mucosa of the larynx. Possible vocal cord swelling. Big things are hoarseness, acute hoarseness, vocal changes. Patients may have a dry cough. Again, have difficulty swallowing. So that's the big thing you want to look for. So you got a patient with laryngitis. What are we kind of monitoring? Respiratory, but specifically, and I heard breathing, and that's good. But what is even more? Airway and breathing. Okay. So we're talking about pharyngitis and laryngitis. We both have difficulty swallowing as one of the problems. So airway needs to be considered. Okay. Treatments, well, voice rest, steam inhalation, increased fluid intake, throat lozenges, antibiotics if it's bacterial, and then the bronchodilators. Again, all of these things can kind of come from, well, it can be bacterial, well, except for the influenza. All of the rest could come from a bacterial source, a viral source, for the most part a fungal source, just an environmental trigger. Anything that could you could breathe in that would irritate the mucosa. That's what you're looking for. All right. So that is the end of the part 1 section of our, I guess, respiratory system part 2. So I'm going to go back over here. And again, that's this respiratory review. These slides I'm going to post. Okay, so some of you kind of came in late. I'm going to post these the alterations review slides. Okay, it's kind of just a condensed version of all the rest of it. We're going to go back to this. Now, this is where, and I know some of you have been kind of freaking out because you don't see the upper respiratory part 2-2. Okay, this is what this is. We're going to start this now. Okay, if I can find the start of it. Okay. Okay, so this is the start of the upper respiratory system, part 2-2. Okay. All right, so we're going to start with our fractures of the nose. Okay. What do you think is going to be the most important thing if you've got a patient that has had a fracture of the nose? Airway. There you go. Airway, and then close behind it, breathing. Okay. But airway, why would you think a fracture of the nose or any kind of facial fracture, why are we wanting to look at airway? Yeah. Any kind of trauma to that region could cause an obstruction. When you're that close to the airway and when you're that close to those respiratory structures, the likelihood of having an obstruction is pretty good. All right, so displacement of bone or cartilage can cause airway obstruction and cosmetic deformity, and or. Number 1 is going to be our biggest problem. Okay. Also a potential source of infection. So probably your airway obstruction obviously is going to be number 1. Infection is going to be number 2, and then we're going to worry about the cosmetic part of it, right? CSF may indicate skull fracture. Okay. We've got fracture of the nose. It's attached to the head, right? It's pretty close to what? The cerebral spinal fluid and the brain. So a skull fracture could easily penetrate the CSF tract, and you could get CSF as a result. Okay, how would we know if we have a CSF leak or CSF drainage? Does anybody know? Okay, it's going to do what now? It's clear fluid, yeah. It's going to be clear. All right, now, if we're talking about fracture of the nose, what else is clear? Yeah, just general drainage, stuff that comes out of your nose could be clear, right? So how could we determine whether it's CSF or if it's just regular old snot? It's not pH, it's something else. We're testing for glucose. Okay, glucose. All right, another quick way is if we've got the blood mixing with our CSF, and maybe it's on a dressing, you're going to see halos around the blood. Okay, so the halos are a pretty good indicator that that's CSF fluid. Okay, so on the dressing, you fold the dressing back, and you see kind of like these yellowish halos, rings around the blood. That's going to be your CSF. If you notice that, if you see clear drainage, and you test it, you're going to want to test it, see if it's glucose, and then it's going to be, that's how you know. Now, you may just have a patient that sits there. You go in to assess, and they frequently swallow. What could that be? It could be the CSF, but it could also be what? Postnasal drip, hemorrhage. Okay, they could be bleeding. Posterior nasal sinuses are hemorrhaging, bleeding, and they're constantly swallowing. Okay, especially with kids. They don't know to say, hey, look, I taste blood, or I've got something abnormal going on. It could be CSF, but it could also be blood. So you obviously or absolutely want to make sure if you've got a patient with any kind of trauma to the nose or the skull or any of these upper airway structures, constantly watch for that postnasal drip, okay, and that frequent swallowing, because it may not be just normal drainage. All right, so fractures of the nose, interventions are going to include closed reduction, just pop it back in place, rhinoplasty, and a nasoseptoplasty. Depends on the damage that's been done. Now, following a rhinoplasty, and really even the nasoseptoplasty, this is probably what they're going to look like. Okay, this is the dressing that they'll come out with. They've got the splint, and then this is known as a mustache pad, or mustache dressing. Now, this picture started out this way, rotated over to the side. Why do you think I would take it and I would flip it up like that? There you go. We want the patient to be upright. Okay? In the book, I think it's laid over on the side. We want the patient to be upright, head of the bed up. Why do you think? The drainage, okay? But also what else? What's going to happen if you take, well, if I take an arm that's broken and I drop it down, what happens? Swelling. Same thing here. We want to minimize swelling and we want to maximize breathing. We also want to minimize the draining into the airway. So we sit up the head of the bed and it helps them to prevent that swelling, airway swelling. Also, just the nose swelling. All right, so that's your rhinoplasty. Now, commonly they'll also pack the nose. Nasty stuff, and I mean it's pretty painful too. But the nose packing, a lot of times they will attach a string to it. Okay, why do you think we would attach a string to the packing? They'll come out in the OR and they'll have a string taped to their cheek. So we can quickly pull it out in the event maybe they're coding, they're having some respiratory distress, airway problems, we can pull that out in a hurry. Okay. So what needs to be part of your assessment? Patient comes out post-op with a string taped to their cheek. What do you need to do every time you go in the room? Yeah, make sure that string's still there. Make sure maybe the packing hasn't fallen out. Also, it could kind of slip backwards. Want to make sure it doesn't slip backwards and occlude the airway a little bit. We don't want to lose any packing. So that's another thing you kind of want to be familiar with. All right. Other facial trauma, and this goes really along with the lines of our nose as well. But any type of facial trauma, our priority is going to be airway, and you're looking for or assessing for stridor. And what's stridor? What causes stridor? Obstruction. This is a step up from a wheeze. Okay, when you have stridor, that means that airway is pretty closed. There's not a lot of air moving through it. Okay. Pertussis, yeah. Whooping cough. Croup. Croup's the big one. You'll see croup, yeah. Regardless, and stridor is basically a sign of respiratory distress. There's limited airway movement through the airways. And if we have limited airway movement through our airways, or I'm sorry, not airway movement, air movement, limited air movement through our airways, we've got a problem, right? All right. Other manifestations we look for: shortness of breath, anxiety and restlessness. Goes back to our cerebral hypoxia. Okay, signs that our brain is now being compromised, the brain tissue. All right, hypoxia and hypercarbia. Okay, why would hypercarbia? When would that be an occurrence? Yeah, so it's increased CO2. If we have facial trauma, well, yeah, if we have limited ability to move air in, we've probably also got limited ability to move air where? Out. So we could retain CO2. Okay? Also, with facial trauma, what also may be involved with facial trauma? The brain. And how would the brain and hypercarbia, well,
the brain is supposed to know when
There you go. The brain has to be able to recognize the CO2 levels to be able to alter the respiratory system, respiratory rate. Okay. All right. Also, obviously, we're looking at decreased oxygen saturations, cyanosis, and loss of consciousness. Any sign that maybe something is going on with the respiratory system, that's your first thing. That's the first thing you need to look for. All right. Next, epistaxis. Well, that's what we talked about. Our posterior nasal bleeding, nosebleed. Okay. It can be an emergency if left untreated. A lot of times, epistaxis will occur following maybe an ENT surgery. Okay, they've gone in for some kind of maybe even a FES procedure or any of these procedures we've talked about related to the upper respiratory system. Epistaxis could occur. They may have to actually bring them back in and cauterize a vessel. Okay, they've just got this constant bleeding that's occurring. If we don't recognize it and treat it, it can be a significant emergency. Okay, this patient can bleed out in a hurry. All right. Nursing care, you want to maintain standard precautions. Position the patient upright and lean forward to prevent blood from moving into the stomach and possible aspiration. Okay, so you lean them forward and you apply pressure. Okay, we don't want to tilt it back. What could happen if we tilt the head back? That's what we always want to do, right? Yeah. Aspirate, bring more blood down into the stomach. Okay, we just want them to lean forward and apply pressure. Okay. Apply pressure for 10 minutes. Also, you can apply cool and cold compresses. You want to encourage the patient not to blow their nose for 24 hours. And I know that's the hardest thing to do, right? You ever have a nosebleed, you just want to blow your nose right away. Try to keep them from doing that as much as possible, because it's just going to open back up. Assess for respiratory distress and also the tolerance of packing or tubes. Okay, they'll actually take tubes, put them in the nose, and blow them up. It's like a little balloon, and it's basically packing in that way. Usually those are for patients that have had significant trauma. Also, you want to provide humidification of air and oxygen as appropriate to prevent drying of the mucous membranes. That may actually be the cause. Drying out of the mucous membranes, maybe we've had them on oxygen for 2 days without a water bottle. You know, that may be the problem with the epistaxis in the first place. All right. Salt pork. Okay, I've never heard of that. Trying to think how that would. It's got to have something to do with that salt part.
Because my dad, long years ago, he had a salt stick. It looked like a pen. He had cut himself. Hold it on there. Wet it and then hold it on there. Just so that it was
Interesting. Okay. Sure. Oh, this. Okay. I'm sorry. Okay, I was fixing to say, boy, that's something. I've heard of the leeches and I've heard of the maggot therapy and all that good stuff, but I've never heard of salt pork coming from pharmacy. I can't. Yeah, and most of this is. I think I did add the epistaxis. What I'll do is I'll just replace this in the part 2 section. Yeah. All right. The next slide, and I'll let y'all finish with this. Next time, we're going to talk about the different types of Lefort fractures. These are just different types of fractures to the face. Okay, you don't necessarily have to know these. Okay, you just have to know Lefort is a type. There's 3 different types of Lefort, but that's a facial fracture. Okay. All right. So, with everything else, if we have a facial fracture, what do you think we're going to worry about? Airway. Same thing. I mean, this is the same type of stuff, just with different types of disorders. You're going to do the airway assessments. You're going to monitor the ability to bring air in and exhale air with the CO2. Okay. You also want to anticipate the need for emergency intubation. Okay. With all of these, You need to be kind of proactive. Patient comes in with extensive damage to the upper airway structures. You need to be prepared because the intubation may be, pretty soon after that. Okay. Is everybody good on those? Okay. All right. These are the different types of the Le Fort fracture, and you can see why these structures would be pretty significant. Type 1 nasoethmoid complex fracture is here. Okay. Type 2, you've got the maxillary and ethmoid complex fracture there, and then the anterior view, you're looking here. Type 3, the fracture line passes through the nasofrontal suture, the maxillofrontal suture, orbital wall, and the zygomatic arch. Okay, significant trauma there. Okay, going across that. But again, that's what you're looking for. You're anticipating the need not only for the emergency intubation, which that would be their first choice, obviously. If they can't get a patient intubated, the structures have collapsed, there's some kind of issue with that upper respiratory system, they may have to do a tracheotomy. Okay. If the patient is not in a controlled setting, if they're not in the hospital, they may even do a cricothyroidotomy. You've seen these in the movies. Patient can't breathe. Some gunslinger, paramedic or physician or somebody's out, takes a pin or some kind of sharp instrument and shoves a hollow tube in their neck. That's what it is. It's a stab wound in the same place you would have a tracheostomy. It allows them to breathe. It establishes an airway. Okay, wouldn't recommend trying that on anybody. All right, but that's an emergency procedure. Establishes an airway when a patient can't breathe in a it's definitely not a sterile setting. It's usually not even a clean setting. Okay, but it's an emergency procedure. It's an emergency stab wound that establishes an airway. Okay, that's good there. Let's just go. All right, neck trauma may also cause upper airway or airway issues. Okay, but it may be caused by a knife, a gunshot, or a traumatic accident. Again, the priority is airway. We're not saying anything new here. But you also want to assess for other injuries, including cardiovascular, respiratory, intestinal, and neurologic damage. Make sure you turn your patients, especially in the ER. Okay. Well, you got to figure out where the trachea and the airway was and put a tube or something in it. I mean, that's basically what they're going to do. Even if all the structures around it are crushed, there's got to be something there that you can, some kind of tube or something you can stick down in that airway to be able to establish a new one, or the patient's not going to make it, basically. And that happens. You'll see some pictures. You could Google traumatic facial facial injury and facial deformations and things like that, and you can see all kinds of stuff. They just have to improvise and find whatever airway is there and left, and that's what they would put a trach or something in. But if they can't establish that, there's no way to save them. So, again, the priority is to assess for and maintain that airway. They've got to find an airway, and they've got to do it quick. Usually it may even be an emergency procedure until they can get a more established or temporary permanent airway. Okay, something more controlled. Assess the carotid artery and the esophagus. Assess for cervical spine injuries. And that's the big thing. Anytime you got neck trauma, even really facial trauma, you have to establish that C-spine first. Okay, establish the C-spine and then the airway. Prevent excess neck movement, all that good stuff. If it's an injury to the face or neck, you have to assume that there's been some kind of spinal involvement until you prove otherwise.
So that's the one time that something.
Well, and not necessarily, because we're going to still, even with a possible C-spine injury, we're still going to do what? We're going to try to stabilize as much as we can, but we're still going to tilt the neck back to do CPR, right? So airway is still first, but we try to keep the spine as stable as possible while we are establishing the airway. Yeah. Yeah, and that's what it is. I mean, and you're trying to see spine. I mean, the jaw thrust is, and all that is established because, yeah, we want to protect the C-spine as much as we possibly can, but still, we're not going to not establish the airway because then it's a moot point. All right, so we do the best we can to stabilize the C-spine while establishing our airway. The good thing is we can potentially do that and kind of take care of both. Okay. Now, obstruction can occur from the initial injury or the resultant swelling, and that's the big part here. Just because they make it to the hospital, everything's okay, we've got them stabilized, this resultant swelling, you've got to be on your toes the entire time you're taking care of this patient, because the airway swelling, you know, it's just like if you break your arm, it's probably going to swell some immediately, but is it going to reach its max swelling point immediately? In most cases, no. I don't know of any case when it's really going to reach its max swelling. Okay, the neck is that mucosa, the inflammation is going to occur not just immediately, but then over a period of time. So the swelling can get worse and worse and worse as you go. Same thing with burn injuries. You can't just let a burn injury that's had possible inhalation injury, they could have swelling that could occur a week later. Okay, it may kind of build up to it, but then that airway has to be maintained for the entire time the patient's in your care. Okay, you don't want to be there and not pay attention to it, and that's when it goes bad, or that's when the swelling occurs. All right, so the same thing here. All of this could lead to an upper airway obstruction. Okay, interruption of airflow through the nose, the mouth, the pharynx, or the larynx. Life-threatening emergency. Early recognition is essential in preventing further complications, including the respiratory arrest. The big thing here is preparation. If you've got a patient with any of the things that we've talked about as far as traumas or injury, what do you need to have available so that you could prevent these complications? Okay, an intubation kit, absolutely. Oxygen, make sure it's hooked up, ready to go. Okay, what else? What else would you have hooked up and ready to go? Suction. I wasn't even on a critical floor, but one of the first things I did when I walked into a patient's room, I'm assessing them and I'm looking to see what I've got over here set up, ready to go. You never know when a patient may, especially where I was at Children's, you never know when a patient may choke on a hot dog. You never know when they may choke on something, and they're not even in there for that reason. Get your suction hooked up and ready, so that way if you've got it, you never know when a patient may have a seizure. Be prepared ahead of time. It'll really save you some headaches later on. And you may not even necessarily have the oxygen hooked up, but definitely have that suction ready. All right, interventions, assess the cause of obstruction, maintenance of the patent airway and ventilation. We've talked about this. The cracked endotracheal intubation may be necessary, and then also the tracheotomy. Patients at risk, have the things at least available and where you can grab them real easy. Okay. All right, some of our chronic upper respiratory system issues. We've got nasal polyps. Nasal polyps are benign great black clusters of the mucous membranes and connective tissues. They often occur bilaterally and are caused by irritation of the nasal mucosa. Or nasal mucosa, nasal sinuses, allergies, or infection. Large polyps may cause airway obstruction and changes in voice quality. And they're going to be treated with inhaled steroids and surgical removal, okay, polypectomy. So there's your great black clusters or nasal polyps. Okay. The next chronic issue, cancer of the nose and sinuses. The tumors are rare and they can be benign or malignant. Often they're seen with exposure to dust from wood, textiles, leather, as well as flour, nickel, chromium, mustard gas, and radium. So what does this tell you? If these are the common, exposure triggers or things that could cause the cancer of the nose and sinuses, how are you going to know if they've been exposed to this? You got to ask them. Occupational history, huge occupational history, okay? Just your basic health history, but make sure that occupational history is a huge component of that, okay? Chromium mustard gas, when might you see a patient that's been exposed to chromium mustard gas? Yeah. Yeah, well, and it's commonly Army. Okay, patient, maybe they're a veteran, and probably not even recent. But you've got some of the veterans that we've got from, World War II, Vietnam, that sort of thing. So make sure you ask that. And they're not going to be able to tell you probably chromium mustard gas, but you've got a patient that's been to Vietnam or been, overseas, war-type setting. That's something that could be considered, okay? Also, we're talking about wood, textiles, leather, flour, nickel, their occupation. Maybe they worked in a factory, whatever. You just got to make sure you ask those appropriate questions. Also, the cancer of the nose and sinuses is typically slow onset. The manifestations resemble sinusitis. So the nasal obstruction, drainage, bloody discharge, taste changes, and pain that persist after treatment for sinusitis. So we think, okay, this patient's got sinusitis, we treat it. It doesn't work. It comes right back. They have this recurrent issue of the upper respiratory system that just won't go away. Well, we need to start considering, hey, maybe do some films, see if there's some type of tumor growing, see if there's something else going on. The diagnosis is going to occur with visualization via X-ray, CT, and or MRI, and a biopsy is going to confirm the diagnosis. Okay. Now, also, local lymph enlargement can occur on the side with the tumor or mass. And then the surgical removal is going to be the main treatment, and it may also be combined with radiation. Depends on the location, the size, the structures that are involved. Okay. All right. Some of the signs you'll see, not quite yet, but head and neck cancer is usually squamous cell carcinoma, slow growing. All right. It usually begins with a mucosa that is chronically irritated and becomes thicker and thicker, or tougher and thicker. It's usually leukoplakia and erythroplakia lesions. And the manifestations are going to include lumps in the mouth, throat, or neck, difficulty swallowing, color changes to the mouth or tongue, oral lesions or sores that do not heal in 2 weeks, persistent unilateral ear pain. Maybe the patient comes in saying, I got an ear infection. Well, we look and there's no issue. They come back next week. I know I've got an ear infection now. My ear's just throbbing. No, we don't see any signs of ear infection. Well, there may be something else growing there. Okay, there may be a tumor, something that's pressing on the nerves there that's causing that pain. Okay. Also, persistent unexplained oral bleeding. It's not on here, but also persistent epistaxis. Okay, we just have constant nasal drainage. The nasal bleeding. All right, we can't explain it. Mucosa is not dry. There's not an issue there. At least take the time to look at it. And I know that's probably not going to be us making that call, but we may be making a recommendation. Also, numbness of the mouth, lips, or face. Again, the tumor starts to impede on the nerve. It's going to, may alter the sensation and movement. All right. Also, a change in the fit of dentures. Unless you're a small child, your mouth it's not supposed to really change. okay? Unless you have some kind of trauma, some kind of injury, you're really not going to have a change in the fit of your dentures. So if a patient comes in and they've complained of, I've had these dentures for 20 years and now they won't fit. We've got to figure out maybe there's some kind of inflammation, some kind of irritation that's causing that change. All right. Also, burning sensation when drinking citrus or hot liquids, hoarseness or change in voice quality, persistent recurrent sore throat, shortness of breath, anorexia and weight loss. These are all signs of potential head and neck cancer. All right, so our interventions, just like with any cancer, it depends on where it's at, what's involved, if it's spread. They may do radiation, chemo, a combination of the two, and then they're going to figure out, okay, can we take it out? Some of the possible results or some of the possible things that can be done, you've got a chordectomy or even a laryngectomy. A chordectomy is when maybe the irritation or the cancer tumor is growing on a vocal cord. They can go in and remove one of the vocal cords or part of the vocal cords. Or they may have to take the entire larynx. Okay? Laryngectomy would be removal of all the structures that are involved in speech. Okay? Following a laryngectomy, this is what it looks like. You basically have, you've got two tubes here, right? On a normal healthy patient, you've got an airway and you've got an esophagus, right? In this case, now the airway has been routed to the neck. The same place you would have maybe a tracheostomy. Okay? They've removed all of the structures here, the larynx, and now it's been rerouted here. One of the key things here, these are separate tubes, so now this patient is not going to be at risk for aspiration, right? When they swallow, they're going down the esophagus. We're not going to have, we've lost that risk for aspiration, so that's a good thing. I guess you take the good with the bad there. What's the big complication that's going to be here, though? If we remove the larynx, communication, complication of the lack of communication. They've lost the structures that allow that patient to talk, okay, and communicate. Now, we do have some devices that they can use. So we'll go ahead and look at that. This is one of the devices. This is the Blom-Singer trapdoor prosthesis. This is a tracheoesophageal prosthesis. And the way this works, here's your trachea, so here's the airway. This is a one-way valve that allows air to come into this one-way valve and through the esophagus. It allows the air to move over the pharynx and some of the tissues involved, so they are able to kind of learn how to use that vibration to speak. Okay? This is not something, again, that they're going to be able to do immediately. They have to relearn how to do that. Speech therapy is a huge part of that. Okay. One of the other things is the electrolarynx, and this is what you've probably seen. It sounds like a recorder, but they're able to personify the vibrations basically in a way that they can learn how to speak again. Okay. Some of the other post-op care, again, priority airway maintenance and ventilation. It's a stoma, so you have to take care of the stoma. You prevent infection. Prevent wound breakdown, all that good stuff. Hemorrhage, just like a tracheostomy, you want to make sure that there's not significant bleeding. Some may be expected, but significant amounts is not going to be good. Wound breakdown, pain management, like any surgery, that's going to be pretty painful for them. They've got to get used to that, that from a pain standpoint, but also, psychologically. Okay, nutrition. For the most part, this is not going to be quite as impactful as a tracheostomy in terms of eating. With a tracheostomy, they may actually fill the tracheostomy tube as they try to swallow. With this, the structures are they're more separate. You also don't have to worry about the aspiration issues, but you do want to encourage the protein. Okay, protein is going to help with the healing, help with that stoma development, and then again, the speech and language rehabilitation. And we don't have this on here, but the psychological considerations. The same as The trach patient, laryngectomy patient, probably going to have even more so. Okay, not only are they having to deal with the body image issues, but the lack of communication. That's a pretty tough thing in itself. Trach patient's probably going to deal with that some too, but they still have the structures that allow them to speak in some way. Laryngectomy patients, they don't have that ability. Okay, they've got to learn to use these different prosthesis devices, or they're never going to be able to speak. Okay. All right. The big thing on discharge communication, stoma care. Make sure they know how to take care of the stoma just like you do. Okay. So discharge teaching begins the day you get them. Okay. The more they can do for themselves, the better they're going to be psychologically, but also it's going to improve their independence. Communication, and then also the smoking cessation. In most cases, the reason they've had the laryngectomy is cigarette smoke. So we want to encourage them to stop smoking. You've seen patients use that stoma for smoking. So you try to encourage that for sure. And then other healthcare resources, anything from social services to support groups. People that, they have the same issues. They can kind of help each other out. Okay, you listen to their issues first, and then you can refer out from there. But you always want to do something first. So listen to them if they have issues. Okay. All right.